morning, good morning, good morning. Hey, Darian, how's it going? Hey, Natalie, what's up? Good morning, everyone. Happy Friday. Very good. Happy Friday for everyone. Very good, very good. Okay. So, well, the dynamic today, what we're going to do is go over this test. So, Darian and I, we're just going to go and show you the question. We're going to give you a little hint. And you guys are going to answer. And then after this, we're going to explain the question a little bit. All right. So that will be basically the dynamic. And Darren is going to do a question, and I'm going to do one. All right. Let's do that one. Okay. Sounds like a plan.
Sounds like a plan.
All right. Let's do it. Let's do it. So we have right now 3 students connected. Perfect. Yeah. Let's begin. Let's do it. Okay, so we're here. Okay, so like I said before, I'm just going to read the question. I'm just going to leave it open, and any one of you can answer. I mean, don't be afraid. So we're here to learn, and there's no stupid answer. Remember, we're all learning. Okay, so number 1, it says, what vein is mapped in order to be used as a reverse graft for the superficial femoral artery? Okay, and remember, we have like 2 types of graft where we use the superficial veins. It could be in situ, all right? Or it could be reversed. When it is in situ, the vein is just going to remain in the same place and all the valves are going to be removed. When it's reversed, you know, the vein is just going to be you're going to, you know, the patient has to go through a surgery. They have to remove the vein, and they will reverse it in a way that the valves are just kind of, now they're going to look down. Before they were looking up, now they're going to look down in, you know, direction of the arterial flow. So who's going to answer this one?
When you say that it stays the same, I think the answer is the GSV. You still have to like take it from where it's at to put it on the arterial side, so it doesn't really stay in its place, right?
I mean, you're just gonna cut one point of the vein. You're just gonna cut the other one, all right? Depending on the area where they're gonna place it, they align it with the area where they're gonna place it, and they remove the valves, all right? And then just like, you know, they do the sutures and the artery, and that's it. Yeah. I mean, it's more complex than this. It's a little bit complex than this, all right?
But
it takes a lot. But they don't have to take the vein out, and they don't have to reverse it.
Okay.
All right. So that's a good answer. Perfect. That's the great saphenous vein, the GSV. And if the GSV cannot be used because there's an ablation on it, or it is insufficient, or there's a thrombosis in the GSV, then the lesser saphenous vein can be used as well. So that's good to know. All right. So good. Perfect. Let's move to the next one. And Marianne.
Okay, so what type of flow is present in the hepatic veins? Are you guys able to answer that for me? Do you remember? Think about the main portal vein and then think about the hepatics. How are they different? Is it pulsatile? Is it biphasic, triphasic?
Heart-phasic.
Right,
and what's the direction?
Towards the IVC.
So, yeah, hepatofugal.
Hepatofugal.
Right? So, it's going to be a triphasic waveform.
Waveform. All right.
By
Yeah, triphasic hepatofugal.
So this one here. All right.
Mm-hmm.
So let's go to the next one. And this one is, what system is mostly affected? If the venous refill time is 4 seconds after a tourniquet is applied in the lower extremity. Remember, we're talking about here, we're talking about the PPG here. All right. So that's basically to look for reflux, and a sensor is placed on the medial side of the ankle. All right. And then the patient is going to do like dorsiflexions, maybe 5, maybe 10, and it's going to pump the flow up. And this system is just going to measure refill time. And this refill time has a magic number. All right. If it is more than this number, it is normal. If it is less than this number, it's going to be abnormal. But then we have to know if the problem is in the deep system or in the superficial system. So how about this one here?
I'm ready, guys. Anybody else?
We are killing you, Natalie.
Nadia must.
We are killing you.
I think it's the venous system.
Well, it's giving you 4 seconds after a tourniquet is applied in the lower extremity. You're good. Yeah. It's going to be the deep venous system. You're good. The thing is, like, you do the exam. If it gives me more than 20, then everything is perfect. But if it gives you less than 20, then a tourniquet has to be applied. And if it keeps giving you less than 20, like in this example here, then the deep venous system is the one that is affected. If it gives me more than 20, it's the superficial system, the one that is affected. So very good. That's the answer. And let's keep going. There.
Is there another way to remember that and never forget?
I think for test purposes, the best way is like remember number 20. Like, hey, 20, more than 20 normal. If it is less than 20, then step number 2, a tourniquet. If it is less than 20, one more time, deep system. If it is more than 20, then the superficial. I guess like that's the best way. If you can find another easier, just let us know. And
I mean, so I'm sorry. So if it's less than 20, both with or without the tourniquet, it's the deep vein system that's affected.
Yes. If it's less than 20 without the tourniquet, you don't know. Remember, you have to apply the tourniquet. Because remember, when you apply the tourniquet, what happens is that you're taking out of the picture the incidence of the superficial system because you're blocking the superficial system. If it keeps giving you less than 20, yeah. And like I said before, if you find like an easier way to get this, you can share it with us, and then we tell to other students, we make this like more dynamic and better. But yeah, it's like, I think the magic number is going to be number 20. All right, Daria, number 4 goes for you.
So what sonographic finding is more related to this angiogram?
Let me show the picture here.
Mm-hmm.
This one is a cool question, let me tell you. It's those
And
questions. That's a good
on
one.
On the RVT, so.
All right, take a look to the angio.
And that's just the right side?
And this one's the right side here.
Yeah.
Right side. And
CCA, ACA, ICA, what's going on? So now, is it flow toward the transducer in the arterial right anterior cerebral artery, retrograde flow in the subclavian, left subclavian artery, high resistance in both vertebral arteries, or aliasing in the left internal carotid artery? So in this case, you're going to look at the image, try to figure out what's wrong, and then try to picture what would happen in the circulation considering what's wrong. Okay.
Aliasing in the left ICA.
aliasing in the left internal carotid artery.
So in this case, what do you think is wrong with the image?
The right ICA is uploaded.
Uh-huh. So now try to think about the circulation, how would the ICA still be able to get flow? How would the patient still be able to get flow?
Reverse.
Something that would usually, it would be different from what you usually get.
Cross.
So you would have a different kind of flow in a vessel. Instead of, like, let's say in the portal vein, when something is wrong, it changes direction. Something is changing direction here. What vessel do you think it would be?
PCA and vertebra.
In the
Right side will have
right
more amount of flow.
anterior cerebral?
Mhm.
Yeah. So it's A. So flow toward the transducer in the right anterior cerebral artery.
That's the one that's
Usually
called.
get it away. So in this case, you're gonna have it towards the transducer.
And that one has a name that's called a cross something.
Perfect. Crossover collateralization. That's the name. Perfect.
And it's only, and that one only, that crossover only applies for the anterior communicating artery, or no?
Yeah. It's going to be through the anterior communicating artery when one of the hemispheres is lacking of flow. And that happens mainly when the ipsilateral internal carotid artery is occluded, or it has a high-grade stenosis. There's not enough flow going to this hemisphere.
Someone's ready for her RVT.
Yeah, I know. It's let me tell you, this is a complex question because you have to think about the anatomy. That's number one, right?
The direction of flow, yeah.
Flow.
And those are the kind of questions that they're going to ask in the RVT as well. So when it comes to the TCDs and the carotids, so take that under consideration.
Yeah. And also you have to know what's going on in here. I mean, angios are not that hard if you understand the anatomy. All right, good job, nice. Let's keep going. So number 5, let's see what's going on with this PVR study right here. Let's take a look to what's going on. I'm just going to give you a little hint in here. Take a look to the ABI. The right ABI is 0.90 and the left ABI is 0.59. And let's see what's going on in here. Right. Brachial pressures, the one from the right is 191, the one from the left is 184. And I think the answer is just gonna take a look at the waveforms, and this here is just gonna give you the answer. The ABI. I can show you the picture right here.
Patient has left leg claudication.
I go with you. Yeah, I go with you. Go like one is the patient has iliac discs. I don't think so. The pressures up here are fine. So this one is, you take this one out of the picture. Study results is within the normal limits. That one doesn't work because both ABIs are wrong, right? Patient has left leg claudication. That's the answer. And patient has right lower extremity incompressible vessels. This one, it doesn't work because in that case, the ABI will be higher. It will give you something like 1.3. And it will be up falsely or abnormally high.
So to always rule out the aortic iliac issue, we just have to look at the first ABIs from the thighs. So right away, if there's nothing wrong with those two, we can rule that out.
Yeah, that's perfect. That's perfect. And remember something, here the patient is using the forecuffs, and when that's the case, those pressures on top, they have to be higher than the higher brachial pressure. That's good to know. All right.
So let's say that they were lower than the brachial pressure, like 180. Then we know that there's a problem. There's an aortic iliac disease.
Yeah.
Okay.
Both legs are affected and the patient is a male, you start thinking about Arterial syndrome. All right. Okay, cool. So let's get going. Good job in here. Nice. Let's go to the next one.
Okay. What is obtained when dividing true positive non-invasive studies by the number of all positive studies by the gold standard? Specificity, sensitivity, positive predictive value, or negative predictive value?
And that one asking it a little tricky.
Yeah.
Saying all positive studies. It's not, which means the false negatives are positive, right? Because they're actually positive.
A false negative is patient. Yeah.
False negatives are, yeah. So
then it's a sensitivity.
Yep.
All right, so.
Got it. So in this case, if you don't know the answer, then, you know, just go by each option. Just do that with every question and go by the process of elimination, you know. With specificity, you're looking at the opposite. You're looking at all the patients that are not sick. So obviously it's not that one, you know. So just do that whenever you don't know the answer. Yeah, you got it.
Correct regarding the this word is very hard for me to pronounce. Poiseuille's equation could be.
Sui.
Yeah, Poiseuille's equation. All right, you guys got it. All right, so how about this one here?
So we want to think about the formula.
Think about the formula, yeah.
That's the, what is the formula again?
Blood flow is.
I can give you a hand in here. Flow here equals pressure, difference in pressure, between 1 times pi, which is a constant number, times radius to the 4th power, over 8 times the length of the vessel times the viscosity of the blood. Okay, let's take a look at this one more time. The formula is going to give you the answer.
I think it's C.
Flow is directly related to the pressure gradient. Perfect, that's the one. Yep. Look at it in here. Flow is directly related to this difference in here. It is directly related to the radius to the 4th power, and it is inversely related to the length of the vessel and viscosity. Yeah, good job, nice. Okay, this one here. Let's go.
It didn't go.
Did it mark?
No.
Right here.
Okay, which artery is compressed by the median archaea ligament in some patients? Superior mesenteric artery, celiac artery, inferior phrenic artery, or inferior mesenteric artery? So
Celiac.
think about your anatomy. Which one? Celiac?
Yes.
That one's easy. You got it.
Celiac in here, and very good. That's good to know. And remember, it has to be in expiration or
Expiration.
Say that again.
Expiration.
Expiration. That's the one. Very cool. Yeah, it's an expiration because remember, diaphragm is just going to go up and it's going to pull up the cilia trunk. Very good. Nice. All right. So let's go to the next one. When it belongs to one arterial ulcer, I have superficial and non-painful, deep and it has trophic changes, deep and non-painful, and then you have the brownish discoloration and the superficial. So about this one here.
Deep, accompanied by trophic changes.
We were talking about this one. Perfect. That's the one. This ones were going to be a lot of the others. So this one here. Okay, very cool. Nice. Okay, let's go to the next one here.
What complications are most related to brachial arteriovenous fistula? Dysymbolization of vasospastic disease, pseudoaneurysm, meningioma hyperplasia, hypertension and cerebrovascular accident, or congestive heart failure and Steele syndrome.
Congestive heart failure.
And Steele syndrome, correct.
And perfect. Remember, I mean, understanding fistulas is very important because it explains the hemodynamics very well.
Mm-hmm.
And one of the things is like when the fistula is just too close to the heart, remember this is a closed circuit. So the flow is just going to go and return so quick to the heart. So the heart doesn't have time for without having this like huge preload. So that will over time develop congestive heart failure. And remember, the Steele syndrome is because the outflow artery is not giving enough flow because basically the fistula is just stealing that flow from the arterial outflow. So the patient is going to have, paresthesias, and it's going to have, pain in the distal part of the arm. Okay?
And that's always with the arterial when there's lack of flow in the arterial system. So for subclavian steels, the Steele syndrome or constriction, those 5 P's are always going to be there.
Yeah, it has to do with peripheral arterial disease. Yeah, very good, nice. All right, let's keep going. And this one, what Doppler modality offers the highest sensitivity to the slow flow? How about this one here?
Continuous wave.
Continuous wave gives you a nice sensitivity, yes, but there is another one that is going to give you even more sensitivity to the flow.
Angio.
Power angio, which is the power Doppler, perfect. And remember, the problem with this one is that when you use it, the frame rate is just going to go down a lot, right? That's the problem with this one. But when you're looking for that very slow, small flow, you're going to use this one here. All right, perfect. Okay, Darian?
Okay. I got all the assurance questions.
Quality assurance one.
What's the statistic value is obtained when dividing the number of true negative non-invasive studies by the number of all negative? And I told you this answer already, so you should be able to remember. We looked at the true positives earlier. Now we're looking at the true negatives. So which one would it be?
Specificity.
Yes.
There's one here. So like Darian said before, everyone here is out of disease. And when that's the case, you're looking for patients who are fine. So specificity, very good. Very cool. So let's go to number 13 in here. Let's say we have this young patient that has calf pain when doing active plantar flexion of the right foot. What's going on in here? There's no any history of trauma or anything. It's just like when the patient is this type of foot motion, there's pain in the area of the calf.
Entrapment syndrome.
Okay, entrapment syndrome, which basically the medial head of the gastrocnemius muscle. It's just going over the popliteal artery, and then when you're doing this, plantar flexion, then basically the muscle is compressing the artery, and then of course the flow to the distal part of the leg is going to be affected, and then there's pain. All right.
It's a good way to remember like those questions between compartment and entrapment. Is the entrapment one, the way that we identify it is with the flexion of the foot.
Yeah.
The compartment one is just young case, like usually a young adult that has suffered some type of trauma, right?
Type of trauma, yeah. And it has to do more with, sports and, or maybe, like you said before, kicking the leg or, any type of trauma in there. And remember, for the compartment, the treatment of election is which one? It's an emergency, let me tell you.
It's a fasciotomy.
Fasciotomy, perfect, that's the one. All right, entrapment in here, very good. Let's keep going.
Where does the coronary vein usually drain? The left gastric vein.
Not the heart.
Yeah, not the heart.
I think it's portal vein.
Correct.
All right. Okay, that's the one. That's the portal vein. Perfect. All right.
Do we ever see it in ultrasound?
I mean, in my experience, I never seen it before. That's a good question. I have to look for it. But the thing is, like, is very close to the portal vein in the entrance and the porta hepatis of the liver. So when there's portal hypertension, this reflux that happens, it's just going to happen in this one first. And that's why the patient is going to develop this esophageal varices, and they're very dangerous. So that's the left gastric, which is the portal vein. Very good. Let's go to the next one, number 15. How about this one? What's the correct one when you are talking about the Doppler Shift equation? And
this one doesn't have pressure gradient inside the formula, right?
I'm just gonna give you the formula now. So Doppler shift equals 2 times velocity of the flow times frequency times cosine of the angle of incidence over the propagation speed of the sound through the blood. Okay, I'll show you the formula one more time here. Times velocity of the flow times the frequency of the transducer times the cosine of the angle divided by the propagation speed of the sound through the blood, which is a constant number, remember.
The constant one?
And it's not 1540, right?
Yeah.
1540 is the one for soft tissue. So let's go here and let's see what's going on.
D.
Doppler shift is inversely related to the sine of the incidence angle. No.
The propagation speed. D.
D. Oh, I understood B. All right, D. All right, D. David. Sound propagation speed and Doppler shift are inversely related. Yes. This and this, they're inversely related. Perfect. All right, good job in here. Let's keep going to the next one.
Okay. What artery is sampled to determine if intracranial basal spasm is present?
And this is the only one that could happen. I mean, that is involved with the vasal spasm. It's just this one. Or it could happen with others.
You can do it as well with the basilar one, But the main one
is the MCA.
MCA.
MCA, right? 120 meters per second.
Mm-hmm.
Oh no, time average.
Yeah, the time max.
120 centimeters per second. All right.
And the normal value is 50 or something?
55 plus minus 12. Yeah, for the MCA. Very good. Nice. Well, very good. Very good. It's a good Friday. You guys are like active and activated and active both at the same time. Let's keep going. Basically here, that's the University of Washington criteria for internal carotid artery stenosis. And it says what velocities are related to 50% to 79% of diameter reduction in the ICA.
Peak systolic velocity of 167 and end diastolic velocity of 45.
Got it. Perfect. More than 125 in systole and less than 140 in diastole. Perfect. That's the one. All right. Very good. Awesome. All right. Remember, for this criteria, you have to use 60 degrees all the time. And it only works for the internal carotid artery. For the common carotid or for the external, it's not going to work. All right.
Okay. What diameter reduction has the distal segment of the superficial femoral artery if the velocity at the stenotic area is 360 centimeters per second and the velocity before the stenosis is 90 centimeters per second? 50, 25, 75, or 60? So if you have 360.
9 times 4.
75.
Yes. And then for this, remember the ratios 2 to 1, 3 to 1. So that would be 4 to 1, correct? Right? Yeah.
Mm-hmm.
Very good.
That's what they're using now.
For the ICA criteria, so it's only 80% to 99% once the end diastolic is more than 140.
You got it. The one. 80% to 99% of diameter reduction, and if it gives me more than 140 diastolic flow velocity. Very good. Nice. Let's go to the next one. And what is the correct statement about this picture? And let's take a look at the picture.
It's so small.
It's the one arterial venous fistula here. That's what we have on the picture. So like I said before, if you understand the hemodynamics for this type of fistula, then you're fine. This will be like a piece of cake for you. And then remember, in your test, you're going to have many questions about this.
Arterial side has the highest sensitivity. Alphabet 15 things. There's a difference between this and a graft, huh?
There are many differences, yeah.
Yeah. Okay. I don't remember. Fistula has a higher chance of getting anastomosis in the veins.
And the venous side, yes.
Okay. And then that means the graft has the higher chance in the artery side. Sorry to just confuse. I'm not sure.
Oh, say that again.
So I'm gonna say then the fistula is the venous side is the one that gets Crohn's anastomosis.
Yeah, yeah. The venous anastomosis is the one that is going to affect the most. It's like the intimal hyperplasia is what we call the universal response of vessels to damage. And because the pressure on the arterial side is so high, you know, veins are not designed to hold this pressure for a long time. So they affect over time. So this one, the venous side anastomosis tends to develop intimal hyperplasia. That's the answer. Yeah, very good. Nice. All right, let's go to the next one.
Okay, what anatomy describes the aortic arch? What are the branches of the aortic arch? Which one?
No, no. I was thinking that.
And remember that one of those arteries has a synonym, so they're called two different ways.
The right CCA branches from the innominate artery.
Correct. Which is also known as the brachiocephalic artery.
All right, that's the one. That's the one. Perfect. Remember, you have your innominate or brachiocephalic trunk, then you have the left common carotid artery, and then you have the left subclavian. And do you guys remember which is the most common anatomic variant for the aortic arch?
Buildings.
When the left CCA branches from the innominate too.
Yeah, they have a common origin. Perfect. That's the bovine arch. Yeah, very good. Cool. All right, let's go to the next one, 21. What branch of internal carotid, okay, read this, very good. Internal carotid becomes a collateral when ipsilateral ICA occlusion is present.
Wait.
Ophthalmic.
Ophthalmic, that's the one, perfect. Remember, the ICA doesn't give you any branches in the neck. So the first one is going to be the ophthalmic, all right? And then in the circle of Willis, it's going to give you the middle cerebral and the anterior cerebral, all right? So what happens in here is a type of collateralization that we call external to internal through the facial artery, and then from the facial to some branches that we have in the eyes that we call orbicular branches, and then from there, it will give you great flow through the ophthalmic, looking for the carotid segment, right? So ophthalmic one. Okay, very good. So 22.
So what criteria defines a diameter reduction of 63% of the renal artery showing post-synaptic turbulence?
How are you supposed to figure this one out?
There's a criteria for this.
3.5. That's it?
What do you mean?
The ratio for is the 3.5, the renal aortic ratio. If it's more than 3.5, there's a problem. Is that what that question is saying? Just because it says
so you're gonna, there's different ways that you can find out if there's something wrong with the artery. The ratio, the velocity, the resistive index, the diastolic ratio. So which one of those is abnormal? And then the abnormal one, you select it. Because the other ones are going to be normal, within the normal range.
Ah, see. I see now. Yes, so the answer is A.
Yes. Got it.
That's the one.
So all these other responses are normal criteria for the renal artery.
Yeah. Are within the normal.
So
are not going to be the answer for it.
Very good, yeah. And remember something, when you do the renal aortic ratio, you have to use the distal aorta, right? It's the one that you're going to use. Don't use mid, don't use proximal, so you're going to use that one. All right, very good. More than 2.5 is abnormal. All right, let's go to the next one, 23. What statement is correct about a reversed greater saphenous bypass? What about this one?
Reversed.
And we talked about this one before, right?
As I probably remove the velocity is higher in the distal. C.
The largest diameter of the vein anastomose to the distal segment of the artery.
The largest diameter of the vein, it is anastomosed to the distal segment of the artery. Yeah, it makes sense. In normal conditions, the largest diameter of the vein is probably like on top, right?
Mm-hmm.
And because this is reversed, now it's just going to be like this. The largest diameter of the vein now is just going to go upside down to the distal section of the artery, right? Makes sense. And remember, the valves in here are going to remain in place. That's the answer in here. Very good.
So it's not flow velocity. Doesn't it go faster?
Where the diameter is
smaller.
Yeah. Which is going to be now proximal, and then distal. The velocity is just going to be low in the beginning, but then later the velocities are going to be. Yeah.
Oh, so it's not. It wouldn't be flow velocities higher in the distal anastomosis.
Flow velocity is higher in the distal anastomosis.
Because wouldn't it mean that that's the smaller diameter?
No, because now the greater diameter is below. Think about it. Think about it.
I don't understand.
Remember, you have in normal conditions, you have the great saphenous vein diameter. And now, okay, let me just go here. Okay, so your GSV in normal conditions is like this, right? And then you have your valves.
Okay. Right. I was thinking it's backwards.
All right. Now this is the superficial femoral artery right here. You have the stenosis in here. And what happens is that now the big diameter will be positioned distal, and the small diameter is going to be positioned proximal. So this is the direction of the valves in here. So high velocity here, and then low velocity here.
I was thinking it was the other way around.
Yeah, it tends to confuse. Yeah. All right, so let's go to the next one.
Where is the common place for deep vein thrombosis of the lower extremity? Soleal sinuses, the femoral vein, posterior tubules, or the saphenous junction.
Distal femoral vein?
That's one, but the most common one are the soleal sinuses.
I don't know how it's most common when they don't even talk about it. It's like not known.
Chances of propagation, they're not that high. And that's why they don't like give this high importance to the soleal sinuses. And that's the most common place for deep vein thrombosis. But the problem with this, when there's deep vein thrombosis in the soleal sinuses, the patient is going to have what we call deep venous varices, and that's painful. It is. That's the problem with that one. But the chances for propagation of this clot, this thrombus, and resulting in pulmonary embolism, they are not that high. That's why they don't like talk too much about this. That's the most common place.
And that's the gastronemes.
No, the gastric are another one. The soleal sinuses are different.
So they have another name though? Soleal sinuses?
Soleal sinuses.
No, soleal vein, either one. Yeah.
You're talking about
the gastrics are different. The gastrics come of the
so the SURAL one.
Soleals are branching out from the posterior tubules or the peroneal veins.
All right, very good, nice. And let's go to question number 25. This is the last one. It says, what condition is suspected when the skin turns white due to one extensive iliofemoral thrombosis? What's going on in here?
Legmasia alba dolens.
Perfect. That's the one. Albumin's white. Perfect. And this is an emergency. What happens in here is that the leg is going to turn white because there is a secondary arterial vasospasm. That's why this one is one medical emergency for the patient. And yes, that's the answer. And phlegmation, cerulean, dolens, cerulean means blue. All right. So this one, the difference between this one here and this one here is that this one develops arterial vasospasm and this one no. All right, very good. Cool. All right, let's see.
What does it mean by vasospasm? If this happens in the legs as well?
It can happen anywhere. Yeah, vasospasm is like a massive constriction of the arterial system, and it can happen anywhere. Yeah, there is coronary vasospasm in the heart, like cerebral vasospasm. You know, this one, there is vasospasm, can happen anywhere. Yeah.
So then why in the brain, in the vasospasm, the velocity goes so high if it's constricted?
Yeah, because you have, remember, if you have less diameter, then you have more velocity. Less diameter, more velocity. There's like a massive constriction of those vessels, so velocity is just going to go high.
So, and that's also happening to the legs in this case?
Happens in here as well, yeah. There is like vasospastic response, and that's why the patient has this white coloration, pale, you know.
Oh.
Right. Yeah.
Okay.
All right, so very good. Let's see how we did. And remember, for vascular, it's very important for you guys to understand hemodynamics and Doppler. That's like the basis for all of this, especially like hemodynamics. That's what's just going to give you the answer. Except for, you know, the quality assurance, all of this, specificity, sensitivity, that's crazy, I know. But once you like, you know, practice this with so many questions, it's just going to be fine for you to understand. So great thing here. You guys did very well, 100%. Very good. So, all right, so round the boys for our webinar, which is going to be on October 23rd, 24th, 25th. It's just going to be, you know, we're going to have a lot of content here to go over. We're going to go over in details. I mean, it's just going to be 3 full days. If we take a look at the agenda here, it's a lot. But yeah, we're just going to go over this, explain this very well. Let me just show you the agenda here. So we have like 3 days. We're going to go over cerebrovascular, hemodynamics, venous, arterial, peripheral arterial, and abdominal arterial as well. So it's just going to be fun. All right.
You'll get 18 CMEs.
You're gonna get 18.
So if you know, if you're in your 3 years, then if you pass your vascular and you take the webinar, then you're done. You know, you don't have to do any courses, anything else. You're pretty much set for those 3 years. So
and if you pass your RBT, that's already 15 credits?
That's 15. This is 18. So you're past the 30 points. So you're good. You're good. You don't have to do anything else.
Perfect. And also, Darian is going to talk to you about you're going to do a webinar, or we're going to do a webinar about interviews, right?
Yeah. So I'm working on a webinar that I'm going to do in November 18th. It's going to talk about interview preparation, resume revision. So now, especially down here in Florida, I don't know where you guys are located. Season is about to start. So a lot of places are hiring. Usually in November, December, January, a lot of places start looking for people. So it's the perfect time to start getting prepared for your interviews or checking out your resume if you're planning to get a job or get another job and stuff like that. So we're going to be doing a presentation on that. And I'll be making the announcements.
Geez, where were you guys when I was going to school?
Right?
We were on vacation.
I wish we had resources like that when I was in school. So yeah, we're pretty much, you know, just trying to come up with different services that you guys can use as a student or as a tech on the real life, not just the educational part of things, but in the field, the things you would need.
Okay.
So
One thing I definitely wish I had more of was documenting. I still get stuck every now and then on like how to choose my words on to describe what I see.
yeah.
Yeah, that's a good one. That's a good one.
Yeah, that's a good one too. So we'll work on it. But yeah, if you guys, if you're in the process of getting a job or find a new job, then I highly recommend it. It's not going to be pricey either. So, all right.
If anybody wants to move to North Carolina, I know they're hiring here.
Oh.
Good. Rodana and Yanni.
All right. So thank you for making it. Have a nice weekend. And if you are one SDMS member, remember they have the conference this weekend. They have a lot of good stuff in there. And
What's this weekend?
The SDMS conference. If you're a member, it's free.
It's free.
It's in Florida though, right?
No, it's a webinar, so
Oh,
it's online. That's why they made it free for the members.
Okay.
All right. Cool.
Yeah.
So all right. So have a nice weekend. Thank you for making it. And I'll see you around. I'll see you soon somewhere. All right?
Thank you very much.
Thank you. Bye.
Bye.